Well, welcome to Grand Rounds. I would say we have the distinct honor of having one of our departmental giants speaking to us this morning. I think Dr. Gibran doesn't need too much of an introduction, but I'm going to share a few points because I think oftentimes for some of the folks that we know and sort of love as our own, we kind of take for granted some of their accomplishments. So Dr. Gibran came to us from Boston University for her burn fellowship, and thankfully for us, she has stayed. I think she is, regionally and nationally known for her advancement of the care of burn patients. She is a phenomenal researcher. She's been continuously funded since 1992, has been an author on more than 170 peer journals, has had so many distinguished positions, of course, amongst them being the president of the American Burn Association. She's a phenomenal faculty. I know has been a tremendous mentor to many residents. In fact, I was telling her this morning, she's the first faculty member I met when I came as a pre-intern interviewing for our department.
Did you came anyway?
You actually told me that you might make me cry. But you didn't.
That was memorable.
But you didn't. No, and it's fabulous for us to have her, and I'm grateful for her to do Grand Rounds, and I can't wait to hear what she has to say today.
Thanks, Deb. Thank you, Deb. Thanks for the opportunity to share an idea that has been bubbling up for 27 years. A couple of acknowledgments, a couple of disclosures. I actually don't have any photos of patients, or maybe a few, and we use them with permission. All of the research that I'm presenting here today is with the funding from the National Institute of Disability, Independent Living, and Rehabilitation Research. It's a mouthful. It's better known as NIDLR. And this project started in 1994 for us with NGRAV, and I want to credit all of the individuals who have helped me form this concept, because it by no means is my own idea. It has been conceived, germinated, and Dr. Lauren Engrav, who some of you may remember, was probably the most influential in these ideas. But there are two other individuals who I really need to acknowledge, aside from the entire burn team, and those are our research coordinators of the past 27 years. Shari Onari and Gretchen Karower embody our clinical research program. Without them, there would be no burn clinical research program. They work 120 hours a week. They touch not just research, but they are involved in all other aspects of burn education and burn care. And without them, there would be no presentation today. The objectives today are to try and share with you the idea that burns are a chronic condition. And I know that none of you, or only a few of you, may care at all about burns, and that's okay. But what I would ask you to do as I'm talking about my little niche, I'd like you to substitute your own specialty. If you're a vascular surgeon, I'd like you to think about the chronicity of your patient's problems. If you're a trauma surgeon, the same. And the reason for that is, frankly, I broke my wrist in June. Minor injury, no big deal. It's a big deal. It's a pain in the butt. Every day I'm in the operating room, I notice it. And so I don't think we appreciate how long our brief interactions with our patients last. And they live with this, and they probably remember our clinic meetings much longer than we do. The next thing is to understand what our options are for using some of the instruments that are available to us for measuring quality of life after an injury or any other condition. And then to try and convince you that we need some way to follow our patients long term, to really focus on their ability to reintegrate into the community and to have a good quality of life and independent living. So I said that this has been a long-term bubbling up idea, but there have been a few aha moments. And one aha moment came last year when I was sitting in M&M's. And an unsuspecting third-year resident was presenting what really was a minor complication. It was a 5-year-old child from Eastern Washington who had been stabbed multiple times in the abdomen by his uncle. And they patched him up in Yakima emergently and then sent him to us, and we did some exploration. And the complication was really a minor one. It was a wound infection. And after all of that, who could really expect anything less? But what the ending comment was really struck me, and that was, he's now come back to clinic 2 weeks after his discharge. He's doing fine, and we've PRN'd him. Now, we know that that child has a lifetime of adhesions. He has a lifetime of abdominal pain that he and his family, who were undocumented immigrants, don't understand. And he has a lifetime of psychological despair because a family member has violated his trust and stabbed him. If this were the burn center, I know that my psychologist would have smothered him with counseling. He would have had wraparound care that would probably exceed what he actually needed, and he would have been plugged into whatever resources could have been found. And I think that we need to think about these things when we are sending our patients out to their communities. So burns has definitely changed over the past 50 years. I took this slide, this graph from a paper by Ron Tompkins, one of the true giants in burns in the past 20 years. And you can see that since the early 70s, the mortality in children has plummeted. Since the late 70s, the mortality in adults has plummeted. Penicillin was invented about somewhere in here. Organized burn care somewhere here. Nutrition and resuscitation were acknowledged here. And what really changed this was the fact that we started cutting away the inflammatory burden of the burn, and we were able to dramatically improve mortality and dramatically increase the opportunity to have patients discharged to a functional existence. What that means, though, is that we need to start focusing not on mortality as an outcome, because it's not that important anymore, and we need to focus on long-term outcomes and quality of life. One national database that we have to better understand what burns are in this country is the American Burn Association's National Repository, not too different than things that other specialty organizations collect. And in a 10-year period, they have about 165 records that we can query. And you can get information in it, such as the etiology, so we know that most of our burns are flames. And you can get information about the fact that most of these are non-work-related accidents, but some of them were work-related. And we can get mortality. And as you can see, again, most of our patients live. But what happens to the rest of them? We have patients who have scars, and you can see that this scar, which looks angry and raised a year or year and a half later, has matured and resolved and isn't so bad. Likewise, this woman with an angry scar on her back has resolved and looks quiet a year and a half out. But there are hidden scars as well. And in 2006, the American Burn Association had a state of the science meeting, and I convinced them that we shouldn't just parade up the same old burn experts with their canned talks on inhalation injury and resuscitation, but rather we should include patients. And we had each burn center was charged with bringing patients, and actually about 100 people showed up. And we integrated them into each of the sessions that we had, each of the breakout sessions, the ones on nutrition, the ones on pulmonary function. And what they shared with us was that leaving the burn center was traumatic. Going back to a community where they had no trust that anybody knew what they were going through was problematic and stressful. They had no idea how to get the dressings that they needed. They voiced the idea that burns change your life forever. One patient talked about the fact that even though he thought that he was just as active, he gained 60 pounds in the first year after his injury. Other patients shared the fact that they couldn't understand why they had long-term shortness of breath. And they've really focused on the fact that community physicians back home didn't understand the sequelae. And so when they had a question and they would say, is this symptom due to my burn? The physician wouldn't know, and they didn't have confidence with that. Another opportunity to listen to our patients was a retreat we had last year. Again, it started out as an opportunity for some of the nursing managers and the physicians to get together and talk about problems to try and solve our patient experience issues with the burn center. And again, at the very last moment, I said, wait a minute, we need some patients here. And so one of the patients shared this, and these are quotes because we recorded it. I did go into a big, deep depression for about 6 or 8 months. I didn't leave the house. You're put back into the norm, and that time for me, I went back into the shell. Does it get better from here, physically and mentally? The pain, the fear? It was a sense you might think that you're okay now, but how is it going to manifest in 3 months, 6 months down the road? And finally, itching. I was burned 32 years ago. Itching is an ongoing daily reality, thermal regulation, or lack of, and lifetime physical limitations. And these are what our patients are saying. And so I, again, would say we can't think just about mortality. We have to recreate ourselves. So the Burn Model System program, which we've been funded with since 1994, again, is a NIDLR-sponsored multi-center program which is intended to examine outcomes following coordinated both acute care and rehabilitation. And it's not just burns that they fund. They first were interested in spinal cord injuries, later traumatic brain injuries, and finally burns. And in addition to each of the programs, the research programs, we also have a National Statistics and Data Center. Coincidentally, the Burn Center is here in our Department of Rehabilitation, which is nice. And there's also a Knowledge Translation Center, which facilitates our ability to reframe our medical jargon into lay language. And so the burn model system has been designed to examine over time health and recovery. We have a strong focus on employment and community participation. It involves a longitudinal registry, which is where the patient interviews and instruments, quality of life instruments come in. And it has a strong focus on dissemination of information to the community. The database collects data at discharge from the hospital, and it collects at that time, our coordinators collect information about the patient before their injury, and then collects from the chart some injury characteristics. These interviews are done either in person, by telephone, or by mailed questionnaire. And we get the usual cadre of patient and injury characteristics, and then we get information about their psychological well-being. We follow these patients for 6 months, a year, 2 years, and then 5 years ago we started following patients or participants as they prefer to call them, every 5 years. And again, some of these are by mailed questionnaire so that the burden of the process isn't excessive. You can see that it's a sizable database, given the fact that it's only ever had 4 centers. We have about 3,000 patients who have 2-year data. We have a fewer number of patients who have 5-year and 10-year data, but that's growing as we mature as a program. One might ask, are these patients representative of what we see in the American Burn Association's database, which burn centers submit all of their data to? And in fact, about 10 years ago, the 2 databases were compared, and when the burn model system data was compared to the more severely injured burn patients in the ABA database, they correlated very well. So the first instrument that I want to talk about is the PROMIS tool, Patient Reported Outcomes Measurement Information System. And I encourage you to look at their website, because this is an incredible compendium of instruments that can be used and mixed and matched to better understand your patients. And when we have used their described PROMIS 29 instrument to look at our patients, you can see that compared to a general population, U.S. sample, which is by definition defined as having a mean of 50, you can see that our patients' physical function 24 months after injury is perceived to be inferior. Our patients tend to have more depression. Our patients also, curiously, they're more tired. They describe more fatigue, and we think that might have to do with the fact that the itching that they have actually interferes with their sleep. And curiously, they actually report higher ability to participate in social roles, actually, than the general public. And it warrants further examination as to why that might be. We also use the PHQ-9 instrument to look at depression after injury, and you can see that 5 years after injury, about close to 20% of our patients are describing moderate to severe depression, as opposed to 10 years, again, no change, 20%. If you look again at the general public in the United States, about 8% of our patients our population reports moderate to severe depression, more in women than in men. But this is significantly higher than the general public. And so speaks to the fact that our patients still need counseling 10 years after their injury. So it is a long-term recovery. So the other way that you can look at a condition such as burns is to use a condition-specific tool. And we have used the burn-specific health scale, which was developed by another burn giant, Andrew Munster from Johns Hopkins. And it has been validated in many different countries over the years, and there are different forms of it. For our purposes, shorter we felt was better, but it focuses on the domains of heat sensitivity, which is something that's unique to burn patients, hand function, since burn injuries are so important in terms of limiting functionality after hand injury, and then emphasizes things such as body image, affect, interpersonal relationships, and sexuality. And if you look again 10 years after injury, you can see that our scores are not perfect, and especially women struggle with affect, body image, and interpersonal relationships, largely likely due to perception of body image. So getting back to what we usually think of, everybody, when they think of being on our rotation, thinks about resuscitation and inhalation injury, and we've got nice grading systems that the pulmonologists can tell us what grade an inhalation injury is. But we don't really think about it much after that. what we have noticed, or what we have found using another tool, the SF-12 health survey, is that, again, 12 and 24 months after an injury, patients who have an inhalation injury have worse quality of life than worse physical component scores, worse physical quality of life than patients who don't have an inhalation injury. But even though we're focused on this and we think about it from a standpoint of research, how often do we or any other burn surgeon actually ask our patients 3 months, 6 months, 9 months, 12 months, how's your breathing? How often do we order a pulmonary function test? So there's a disconnect, and we need to get that right. We need to make sure that we're hardwired to say, oh, this patient had an inhalation injury. This patient should be getting pulmonary function tests, and we should be making sure that we understand what their capacity is to work in this environment or that environment, or to actually run a marathon. But as I say, there's a disconnect. The other thing that we focus on is resuscitation, and anyone who has been on the service recently knows that we've had some major resuscitations, and most of them have gone well, but some of them have ended up with compartment syndromes, and we see inability to ventilate, requiring escharotomies. We see poor perfusion to the extremities, requiring escharotomies. We see abdominal compartment syndrome, requiring a decompressive lap. We need to place chest tubes. Patients get ARDS. And 10 years ago, we actually described a syndrome which had not been recognized before in patients who have massive resuscitation, and that was elevated intraocular pressures. And we noticed in our patients that they would have intraocular pressures as high as 90, which of course is associated with optic nerve ischemia. And this could be corrected by a very simple lateral canthotomy, but you have to think about it. And so this now is part of our standard of care. And I would argue that 6 months after injury, how many of us ask our patients, how's your eyesight? Do we refer them to an optometrist or an ophthalmologist because it's in our, more likely I would say, we walk into the room and say, oh, your scars look good. Oh, Dr. Wood, you're arranging your arm really well. Thanks for doing your exercises. Again, a disconnect. And we need to hardwire these concepts of what's important to our patient. Our patient probably doesn't really remember that he was looked like the Michelin Man for 48 hours, but he does remember that he can't see very well and his eyesight is worse than it was before his injury. So we focus on complications. We want to make sure that our patients don't have urinary tract infections or pneumonias or wound infections. But do these have long-term ramifications? And it turns out they do. When we looked again at the SF-12 data for the physical component scores, we saw that if they had a urinary tract infection, poorer reported physical quality of life. Same with a pulmonary embolus or a DVT. Same if they had an acute kidney injury. We all would concede that if you have one complication, odds are you're going to have more than one complication. And so our data suggest if you have 1 to 3 complications, again, your physical component scores from the SF-12 instrument are going to be worse at 12 months and not much better at 24 months. And curiously, or maybe not curiously, if you have 4 to 6 complications, it's almost double the poorer quality of life. And again, it escalates with more than 6 complications. So what I would argue for you is that burns represent a chronic condition. And we need to come up with creative ways to address this. But again, I'm going to ask you to cross out burns and replace whatever your condition that you treat is. So last year, we were invited to participate in the Clinical Practice Innovator Program here. Thank you, Dr. Pellegrini and Flum, for facilitating that. And I sat and looked at this slide, which I have borrowed from Dr. Pellegrini, and I thought about, what could I do? How could I apply these ideas to the burn unit? And I thought, oh, medical homes. Oh my goodness, I'm a surgeon. Diabetes, glucoses, blood pressures. No, that's not for me. And then driving in traffic one day, I thought, our patients need a fully developed medical home so that we can track their complications and track their psychological and physical recovery. At about the same time, we recognized that burn patients, like other critically ill patients, struggle with what's known as post-intensive care syndrome. It's now widely recognized that patients who have been in an intensive care setting for a prolonged period of time have significant issues with cognition, with mental health, and with their physical health. And it's recognized nationally that we need new strategies to mitigate these issues. There was a white paper in 2012 which actually addressed the need for a patient-centered medical home. And this has been adopted by the post-ICU community, the intensivists. And at least one study has demonstrated that patients who have been in the ICU for longer than 48 hours actually would probably benefit from a post-ICU clinic that addresses the issues that we have discussed. And 68% of the patients that were seen in this clinic actually had identified needs for further referrals to specialty clinics, suggesting that maybe if we had a program that could focus on this, we would not be leaving patients in the lurch. So what could we follow in a long-term clinic with burns? Well, certainly monitoring physical recovery, the usual scars, contractures, shortness of breath, which we should be doing better, miscellaneous other chronic conditions and symptoms, including being able to think about ophthalmologic issues and referring patients for their eyesight. Clearly, we need to have better psychological outcome measurements, and we need to be tracking these. If there's one thing that we see with our patients from rural settings is the inability to get our patients psychological counseling and inability to find providers who will see them for their depression or their post-traumatic stress. And we need to focus on community reintegration, specifically making sure that our patients are getting back into the workplace and into the school, so that we can have a patient like this with limited range of motion who 3 months later actually has resolution of his scars, decreased pain, and a better range of motion. So I know you're thinking, well, big catchment area, how do we do that? And our patients would say the same thing. Again, at our retreat last year, one of our patients said, my parents live in Spokane. Being so far away was very difficult. Another one, we're 2.5 to 3 hours away from the burn center. We couldn't get OT or PT support and had to drive to see you once a week. And then when it takes 3 weeks to get an appointment, I feel like I'm losing my gains. And so we need to find creative strategies for following our patients without making them drive to Seattle and find parking. We did a needs assessment again, and we wanted to know what are the barriers to patients' recoveries. And one of the questions had access and then the usual symptoms. And again, you would think that race and ethnicity at Harborview would not be a problem, but when we broke our data down by whether or not patients were Hispanic or not, or whether they were white or not, our minority patients, our people of color, our Hispanics, and these were all English-speaking Hispanics, perceive that access to care is worse than their non-Hispanic and white counterparts. And from my perspective, this was shocking to me. But it clearly presents a challenge that we can rise to, and we can find ways to reach these populations in a way that they appreciate. And so it gives us insight into our burn survivor concerns, their concerns about their ability to access care, and our need for continuous patient education. So Tom Pham has been really the maven in our division for introducing technology. I follow him knowing that this is the right direction, but I do it kicking and screaming. And he has introduced video conferencing to our clinic, and so now we're able to see patients from afar. We have established a burn picture program where patients actually send us static pictures, which allows us to provide follow-up and avoid unnecessary visits. He has a whole compendium of burn care educational videos, which our patients use to improve their therapy. We have long had our virtual reality program for pain control, and now under the NIDLR funded process, we are studying the feasibility of a home virtual rehabilitation program using the Connect hardware infrastructure to see whether or not virtual rehabilitation might improve patients. And so these tools were really developed so that we could reach our patients in the hinterlands. But the reality is, when we look at our patients who take advantage of burn pictures, most of them actually are in the Seattle corridor. And when we look at who's utilizing our video encounters in clinic, again, a strong cadre of people who are using it from the King County and Western Washington corridor, which suggests that patients really appreciate not having to come to Harborview and find parking. Another opportunity for patients to have self-directed care is a video where we showed patients how to remove their own dressings so that they could then send us burn pictures. And here you see a picture of Dr. Pham doing a televisit with one of our patients in a closet in our clinic. This actually has been championed by the acute care nurses and the clinic nurses as a real step forward, and it has been helpful in actually decreasing our clinic volumes, which can become tedious. Again, just emphasizing the videos that he has created with our therapists and our nurses related to both exercise and wound care. And these now, many of them are also in Spanish, addressing the issue that our non-English speaking population struggles with their home care. And so I would argue that any type of medical home for trauma patients or burn patients would have to have the option for in-person visits. But because of the challenges of both our volumes and also the patient's need to travel, probably needs to have some sort of video conferencing or static picture option as well. So how would you measure whether or not this was a success? I would say one way would be to track recidivism. With the whole opioid crisis and our recognition that our patients actually have true narcotic needs, at least for the first month after injury, we could probably use opioid utilization as a metric for success for such a program. We could track community integration, independent living. I think an important one would be employment, and we understand a lot about employment after injury. We know that there are early barriers which are physical due to the need for wound care and immobilization, splinting and whatnot, But the late barriers also are issues that we need to overcome, and those are related primarily to psychosocial factors. In spite of that, in spite of the fact that this is such an important problem, when we did a survey of burn centers across the country, we had 35 responses, and you can see only 5 of them focused on completing workman's comp paperwork, and that's less than 15% of the burn centers actually really even think about patients getting back to work. In contrast, we have a very well-developed vocational intervention after burn injury. This begins actually during hospitalization, and it continues with the stalwart work of our vocational counselor, Sabina Brich, who is in constant communication with patients and their employers and works hard to try to find some sort of accommodations just to get the patient back into the workplace. And again, one of our patients who is actually a researcher and was involved in a very highly profiled event when the helicopter crashed at the Seattle Center, said, you know, when you sent me back to work, I was absolutely convinced that it was too soon. I wasn't ready. But as I look back on it, it was the best thing for me, and getting back out of the house and feeling sorry for myself and getting back into the workplace allowed me to recover quicker. And so I would say that a medical home could address many of the goals of the transformation of healthcare. It could improve efficacy, and it could be high value so that patients don't waste time seeking expertise from people who don't understand the process. And I think that it needs to involve smart innovation in the form of technology. And I think that it has the opportunity to be able to differentiate burn-related or trauma-related issues as well as non-related medical morbidity, and we may be the best to be able to provide that. So I know what you're thinking. This is never going to happen in a surgical clinic, and I don't think it should. I think that this belongs in a family practice clinic or a rehab clinic with people who actually understand the condition but may not be surgeons. And so I leave you with the big picture. Delivery of regionalized burn care has evolved. There are some guiding principles, I think, that has contributed to this evolution. There's a huge amount of burn prevention that has resulted in decreased numbers of large burns, although any resident who rotated this year on our service would argue that that doesn't seem realistic. It needs to involve self-directed recovery, and we need to empower the patient to do things on themselves, with themselves, for themselves, rather than being paternalistic. It's going to require allocation of resources, and we're going to probably have to find ways to partner with outside physicians to achieve our goals and to coordinate regional burn care. This will all require team management and coordination, but I think that in the long run, we're going to be able to significantly impact our patients' experience and their quality of life by using emerging technology. And I think that one of the driving forces behind this are going to be finance, because I don't think that we can afford to have people who are otherwise be able to enter the workforce be unemployed. So I thank you for your attention, and maybe you're pleased that I didn't discuss genetics or signaling pathways or something else. Thank you. Doug, thanks.
So Nicole, that's incredibly impressive and inspiring. I think I didn't realize the extent of your involvement in this aspect of patient-reported outcomes. That kind of I like the fact that it connects with Dr. Andre Pusik, who was here just a couple of months ago as our visiting professor talking about patient-reported outcomes. And obviously, it's really clear in burn injuries, but you made a good point that all of the rest of us that care for patients in our own specialties and subspecialties have related issues of chronicity. So following, you inspiring us, what are steps that faculty or residents who are interested in and see an opportunity here of being involved or getting more knowledgeable or impacting the chronicity of care, what are things we could do to follow some of the model of what you've done, which is listening to patient voices early on and then turning that into attention to care that's well beyond the acute phase that we pay most attention to?
I think that last point that you made is really very important and is a great beginning. It is a really powerful message when we actually listen to them. I've had multiple opportunities to do that, and I know that Dr. Krisick here is getting patients to provide input into decisions that are being made, I think, regarding redesign of the ICU and reorganization of the ICU teams. She gave a very compelling talk last year at the CPI forum. That's number one. Number two is actually educating yourself about some of the options, because understanding when to use a condition-specific instrument versus an instrument such as PROMIS or SF12, and to understand the psychometrics is a science all to itself. And I think that the only way that we as surgeons are going to be able to do that, or do any other research, is to partner with people who are experts in those tools. And there are some experts. We have an expert here in our Department of Rehabilitation who I've worked with for 5 years, and I never realized that she's a national authority on it, really. And there are opportunities to collaborate, and I think that that's how we need to build bridges across the UW medical infrastructure, because I don't think that we can recreate the wheel here and just assume that we can just generate it de novo. And I think there are multiple opportunities, and there are many people who want to collaborate on projects like this, and they provide the expertise. So knowing what questions you want to ask is an important first step. And I think the way to know what questions to ask is to learn that from our patients. Okay. Comments?
I thought it was fantastic. The concept is fantastic, and it's one that in your last slide, when you put finances at the bottom, is going to influence, I think, the future of surgeons altogether. And the issue here is that we become individuals, I think surgeons, who specialize on a field. As you pointed out, this is burns, but it could be whatever else we're doing. We know a lot about the disease, but we tended in the past to just focus on the acute event and then say this is for somebody else to take care of. And those somebody else's have emerged in the world. When I was president of the college, I remember that one of the biggest things that I had to deal with was with our colleagues of anesthesia who had created the surgical home. And they said, we are the owners of the surgical home because we are clinicians. We're also in the operating room. We see the patients beforehand. We evaluate them. We put them to sleep. We care for them on the intensive care units because the surgeons don't want to man intensive care units. And we then could extend that and follow up and provide actually the medical home, and then disperse whatever financial rewards were in terms of professional fees, disperse them from our side 2 surgeons, 2 other participants on the care team. So when I think of what would be a fantastic evolution in the minds of younger people that are joining surgery, would be to make the switch from the current, what I see in our clinic, what I've seen for many years, resident presenting somebody to me and saying, this is not a candidate for an operation for reflux. You know, patients are not candidates for anything. They have a problem, and they don't come to be told, this is, you know, you're not my nail. I just have a hammer, and you don't look like a nail, so go somewhere else. But instead, immerse themselves into the problem and saying, because I have some expertise in here, I got to solve a problem. And if the problem requires an operation, doing the operation then requires that, in the case that you presented, and in many other cases, perhaps not all specialties, that we then follow up continuously, and the patient has the sense that his or her care is coordinated by an expert that knows about intraocular pressure, for example, and not just saying, I don't know, I took care of the back burn, you cannot see well, we have ophthalmologists that can take care of you, and then they go into ophthalmology, and we fractionate the case. This would be a great opportunity and a great model to say, we're a centerpiece, and we take responsibility for it. That doesn't mean leaving other specialties out.
No.
We need rehab, we need psychologists, we need everybody else, but we can coordinate that care and become the home for those patients that have undergone procedures by us.
Thank you. Thank you for that.